So shall we start? Say yes, we'll start. Yes. Okay. So coming to the next part of our discussion, where we're going to go into the very important thing in auscultation, which is going to be areas of auscultation. Okay. So if you take areas of auscultation, we first have mitral area. Okay, mitral area, which is also called as apical area. Okay. If you see this picture, in this picture, you can clearly see this is the mitral area, okay, which is called as apical area, apex, okay, which is left fifth intercostal space, 1 to 2 centimeter medial to the mid clavicular line. So this is, if you're going to take this as a mid clavicular line, okay, it is 1 to 2 centimeter medial to the mid clavicular line. That is called as your mitral area. Then next we have tricuspid area. Tricuspid area. What is this tricuspid area? Tricuspid area is going to be the lower sternal point at the left fifth intercostal point space. If this is a sternum, it is the near the sternum. It's a point near the sternum in the fifth intercostal space. Okay, fifth intercostal space. Next is going to be pulmonary area. Pulmonary area. Pulmonary area is the point near the sternum in the left second intercostal space. Okay, left second intercostal space. And aortic area is going to be the right second intercostal space near the sternum, just lateral to the sternum. Okay, so that is going to be the aortic area. Okay, so that is the second intercostal space just lateral to the sternum. Okay, so these are the important areas we are going to see here. Okay, so coming these areas, whenever you see these areas, you see for the apex beat, which is going to be the fifth intercostal space, 1 to 2 centimeter to the mid clavicular line. You're going to just see. Okay, and if you see the apical impulse, the apical impulse is going to be, okay, so it is going to be seen within two rib space. Okay, within two rib space. Okay, and it will be felt as a tap. Okay, it will be felt as a tap. Okay, it is felt as a tap. Okay, gentle tap, 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 tap. Okay, it's a gentle tap. Okay, in the fifth intercostal space. Okay, and it is between the two ribs, and it is going to be a size of 1.25 centimeter into 1.25 centimeter area. You are going to feel the apical impulse. Okay, apical impulse. Whenever there is a change here, okay, whenever there is a change here, what is going to happen? The apical impulse is going to change its quality. Okay, apical impulse is going to change its quality. So what are the different types of apical impulse you will get in our practice? Okay, just come and show here. Okay, so whenever you take the apical impulse, okay, so this is maximum can go to an area of less than 2.5 centimeter. Okay, whenever it is more than 2.5 centimeter, then it is going to be abnormal. Okay, so apical impulse is going to be a gentle tap. Okay, and this tap, okay, is going to be abnormal whenever it is going to be having some valvular pathology. Okay, so the first one is going to be tapping apical impulse. Tapping apical impulse. Where you will get a tapping apical impulse? The tapping apical impulse is usually whenever you feel the left ventricular apical area, okay, during isovolumetric contraction, you're going to get a tapping apical impulse. It means that the duration of the apex beat is less than 1/3 of the systole. Okay, less than 1/3 of the systole. You will feel as a it's a prolonged tap than the normal tap. Okay, so that is going to be seen in mitral stenosis. So you're going to see a tapping apical impulse in the mitral stenosis. That is very, very important thing. Okay, you will get a tapping apical impulse in mitral stenosis. Okay, then next is next important thing is you are going to have an apical impulse called as hyperdynamic apical impulse. Okay, apical impulse. What is this hyperdynamic apical impulse? Okay, so hyperdynamic apical impulse involves more than one space of the intercostal space. Okay, it involves more than one space. Okay, so it is going to cross one space. Okay, more than one space, and it is going to occupy. Okay, around one third to two third of the around one third to two third of the total duration of the systole. Okay, total duration of the systole. Okay, so this is going to be again very important. Okay, total duration of the systole it is going to occupy. Okay, then next is sustained or heaving apical impulse. Sustained or heaving apical impulse is usually more than two third of the systole it is going to occupy, but it is going to be there within one space only, within one space only. Okay, so this is very important. Okay, very important. Okay, so where you will get hyperdynamic apical impulse? Wherever there is hyperdynamic circulation. Okay, so whenever the patient has anemia, very AR, okay, all these conditions you will have a hyperdynamic apical impulse. Okay, where you will get a sustained apical impulse? Whenever the patient has a resistance for LV outflow. Okay, எங்கெங்கெல்லாம் வரலாம்? Aortic stenosis வரலாம், hypertension வரலாம். Then sometimes you get diffuse apical impulse. Okay, that is also more than one space. Okay, and it is seen in dilated cardiomyopathy. Okay, dilated cardiomyopathy. Then you can get double apical impulse or double kicking apical impulse. Now, yesterday also I told you, I think so. You get in HOCM, mainly in HOCM. Okay, where you get absent apical impulse. Absent apical impulse whenever the distance between the apex and the chest wall is increased. Okay, cardiac tamponade, constrictive pericarditis, emphysema, pleural effusion behind the rib, dextrocardia, obesity. On all these conditions, you will get an apical impulse which is usually absent. Okay, usually absent. So here I will give you one flow chart also. Okay, that will be easy for you to assess the apical impulse. Okay, that is very easy for you to assess the apical impulse. Okay, so whenever you see apex peak, you see whether it is forceful or not. Forceful or not. Okay, if forceful or not, you are going to first see. No. Yes. Okay, no. Then next is S1 palpable. S1 palpable. No. Yes. Okay, whenever S1 is not palpable, okay, it is normal apical impulse. Okay, when S1 is palpable, okay, it is going to be tapping apical impulse. It is usually seen in mitral stenosis. Mitral stenosis. Mitral stenosis. you are going to have a sustained apical impulse. So whenever you have a sustained apical impulse, okay, sustained apical impulse, then if it is a sustained apical impulse, then it is going to be heaving apex beat. Okay, when it is not sustained, okay, it is going to be hyperdynamic apex. Hyperdynamic apex. Okay, the hyperdynamic apex is diffuse. Heaving is localized. Okay, this already I have told you. Okay, so whenever you have a hyperdynamic apical impulse, it means that it is going to be conditions like AR, very, etc. Whenever you are going to have a heaving apical impulse, okay, it is going to be AS. Okay, so here it is going to be ventricular dilatation, volume overload state. Okay, it is going to be volume overload state. Here it is going to be pressure overload states. Okay, so this is very important. Okay, very important. Okay, so these are very important things which you have to consider whenever you have any apex beat being asked in the exam. Okay, apex beat being asked in the exam, and you should be able to answer it. Okay, very important thing. Okay, so I will give you a overall one flow chart or a table that also will be easy for you. Okay, I will attach to your routine this thing, or that will be easy for you. Okay, so I'll attach one this thing. This is going to help you in your exam. Okay, this is going to help you in your exam. Okay, so these are very important thing. Okay, then next is after this, next is we'll come to the important thing in cardiac auscultation, which is going to be murmur. Okay, murmur. So having seen the different areas of murmur, so what are the murmurs we have to consider? Okay, what are the murmurs we are going to consider? Okay, so whenever you have auscultation, murmurs are very important, and when murmurs are there, there should be a grading for murmurs. Whenever there is a grading for murmur, you have to consider for thrill whenever the murmur grade is more than 4. Okay, 4 or more than 4. So what is the grading for murmur is called as? Okay, so the grading for murmur is called as Levine staging of or grading of murmur. Okay, so if it is going to be, one thing you have to remember is grade 4 is associated with the thrill. Okay, and grade 5 it is even without a stethoscope. Okay, and even on entering the room. Okay, 5 6. Okay, that is very important. So it is muffled, soft, loud. Okay, or very soft, loud. Okay, you can remember anything. Very soft, loud. Here it is thrill. Okay, no stethoscope, into the room. Okay, so these are the thing. Okay, so thrill, what is thrill? Okay, thrill is a palpable murmur. Okay, how we see that friction parameters like that, we are going to have here thrill. Okay, it's a palpable murmur. Okay, initially this uh, thrill is called as purring of a cat. ஓகே, இந்த கேட் நீங்க வந்து உங்க ஐபேட் வச்சிருந்தீங்கன்னா அந்த கேட் வந்து ஒரு மாதிரி ஒரு சவுண்ட் கொடுக்கும். ஓகே, ஸோ அந்த தட் இஸ் கால் டாக்கிங் டாம். ஓகே, அதுல ஒரு பர்ரிங், அந்த அந்த நீங்க வந்து இங்க உங்க கையை இங்க வச்சுக்கிட்டு உங்களோட த்ரோட்ல வச்சுக்கிட்டு நீங்க பேசும்போது ஒரு வைப்ரேஷன் வருது இல்லையா, அந்த வைப்ரேஷனுக்கு பேரு தான் வந்து பர்ரிங் ஆஃப் கேட். ஓகே, கேட்டை நீங்க பிடிக்கும் போது கேட் சத்தம் போடும்போது ஒரு ஃபீல் இருக்கும். தட் இஸ் கால்ட் பர்ரிங் ஆஃப் கேட். ஓகே, ஸோ தட் இஸ் கால்ட் த்ரில். ஓகே, ஸோ வேர் யூ வில் கெட் த்ரில்? ஓகே, ஸோ whenever you have the heart of the patient, okay, whenever you have the heart of the patient, over the base of the heart at the second intercostal space, right, just here second intercostal space lenda, then it is going to be aortic stenosis. Okay, then at the apex, mitral regurgitation. Okay, To the left of the sternum in the second intercostal space, then it is going to be pulmonic stenosis. Okay, to the left of the sternum in the third to fourth intercostal space, actually it is around third intercostal space, it is going to be VST, which is called as Rogers murmur. அங்க ராஜர்ஸ் மர்மர் VST மர்மர் பேர் வந்து ராகர்ஸ் murmur. Okay, so these are few examples you have to consider. Okay, coming to the murmur. Okay, murmur. Okay, so whenever we come to murmur, it is very important to know the characteristics of the murmur. Okay, so first is I'm going to draw systolic and diastolic murmurs. Okay, systolic and diastolic murmurs. Okay, so these are the areas of auscultation which I already told. One more thing is I didn't tell about the third intercostal space, which is going to be called as Erb's point. Okay, which is called as Erb's point. Okay, it is where we hear the murmur of aortic regurgitation, valvular aortic regurgitation, and HOCM or HCM. Okay, HCM. Okay, அது ஒரு extra point. Okay, so okay. So whenever you have a person is coming to you with valvular heart disease, then you put your stethoscope and you hear for the murmur. Okay, so what are the murmurs you get to see and how you are going to feel it? Okay, just I will erase it and I will rewrite it. Okay, okay. So this is the cardiac cycle. Okay, where we are going to have S1, S2, S1. Okay, as I told you, this phase is going to be called as isovolumetric contraction, ventricular contraction. Then here you are going to have isovolumetric relaxation, rapid ventricular filling, and passive ventricular filling. Okay, passive rapid ventricular filling and active ventricular filling. Okay, so these are the phases. Okay, now whenever you have a patient, okay, patient coming to you, okay, and this patient is going to have a lot of scenarios, okay, lot of scenarios, and based on these scenarios, how you're going to make a diagnosis, okay, make a diagnosis. Okay, so whenever you have any patient coming to you with the heart disease, okay, heart disease, then you have to see what kind of heart disease, how it is going to correlate. Okay, first is this part, early systolic murmur. Okay, early systolic murmur occurs in two conditions: mitral regurgitation, tricuspid regurgitation. You can ask me, I have studied all through my clinical class that if it is going to be mitral stenosis, then mitral regurgitation, then it is going to be pansystolic murmur. And we are discussing here as a case of early systolic murmur, how it is possible. Okay, so how it is possible is in acute MR and TR. Okay, what is going to happen is this is the heart of the patient. Okay, and this is going to be held in position with this papillary muscles. Okay, whenever during early systole occurs, this patient having acute MR, this muscle will be cut. Whenever this muscle is cut, what happens? The blood will try to enter here. When it tries to enter here, what is going to happen is our heart contraction further tenses this muscles. When it tenses the muscles, the murmur will disappear. So this is usually seen in acute MR and TR post-MI patients, post myocardial infarction. Okay, then what happened? We know whenever there is after isovolumetric contraction, there is going to be opening of the what is going to happen? There is going to be opening of the aortic wall and the pulmonary wall. So whenever it opens, it makes a sound. And this sound, which is here in pathological condition, which is called as ejection click. Okay, ejection click. In ejection click, what is going to happen is the patient will have an ejection click, followed by the pressure in the ventricle will be more. So you get a crescendo pattern, followed by you get a decrescendo pattern, okay, because the pressure in the ventricle will be equal to the aortic pressure, and after some point the aortic pressure will increase. For that reason, you get a crescendo decrescendo murmur, which is also called as a diamond shaped murmur, which is seen as ejection systolic murmur in cases of aortic stenosis, pulmonic stenosis. Okay, pulmonic stenosis. Okay, so these are the two important murmurs you will get. Okay, and this murmur, okay, this murmur will radiate to carotids. Similarly, you get ESM in another one condition, which is going to be seen in the same similar pathology, which is going to be HCM or hypertrophic cardiomyopathy. Here, it do not radiate to carotids. Not radiate to carotids. Okay, that is very, very interesting. Valvular pathology will radiate to the carotids. Non-valvular pathology will not radiate to carotid. Okay, followed by the next thing is I told you, you get a click here. Okay, what is that click? It's a non-ejection click. Non-ejection click. Okay, non-ejection click. Okay, is there. Okay, now what happens? There is a condition where this is the mitral valve. Okay, whenever okay, so what happens is mitral valve, whenever the pressure in the patients increases, whenever during the end of the systole, what is going to happen is this wall moves upwards and there is a space which is created here. Okay, when a space is created here, what is going to happen is the patient is going to have a murmur in the late systole, and this late systole murmur, okay, which is here during the late systole with a non-ejection click is called as mitral valve prolapse murmur, which is a late systolic murmur. Late systolic murmur. Okay, late systolic murmur seen in mitral valve prolapse, which is associated with a non-ejection click. Okay, which is associated with a non-ejection click. Non-ejection click. Okay, then next thing is a patient who has mitral regurgitation. Okay, whenever the blood is trying to enter into the aorta, it will also try to enter into the left atrium. Okay, and because of this, all through the systole, the patient is going to have murmur. All through the systole, the patient is going to have murmur. Okay, so because the patient is going to have all through the systole murmur, it is going to be a case of pansystolic murmur, and this pansystolic murmur is here in mitral regurgitation and tricuspid regurgitation. Here in mitral regurgitation and tricuspid regurgitation, which is also called as holosystolic murmur, all through the systole. Holosystolic murmur. Okay, holosystolic murmur. Next is coming to the diastole. Okay, diastole. Diastole immediately after, so I'm going to split it and make it here. S2, S1. Okay, S2 and S1. Okay, whenever there is a diastole, okay, the blood which entered into the aorta immediately will try to run down. Okay, since the valves are closed, it cannot enter into the left ventricle. But here the valves are flabby. Because of the flabby, what is going to happen is the blood is going to drop into the ventricle. Okay, and this is going to be called as early diastolic murmur, which is going to be a decrescendo pattern of murmur. Okay, and it is seen in aortic regurgitation and pulmonary regurgitation. Pulmonary regurgitation. This pulmonary regurgitation murmur is also called as Graham-Steele murmur. Graham-Steele murmur. Okay, Graham-Steele murmur. Then I told you whenever during the immediately after the period of isovolumetric relaxation, there is going to be opening of the mitral wall, and that is going to be increased whenever the pressure in the left atrium increases, and that is called as opening stamp. Okay, opening stamp. After opening stamp, what is going to happen is these patients will have a murmur, the murmur which is going to be like this and like this. Okay, the murmur is going to be like this and like this. Okay, so this murmur is a murmur which is going to be a rough rumbling murmur, which is low pitched. Okay, followed by a pre-systolic attenuation. Pre-systolic attenuation. Okay, with a loud S1. And this kind of mid-diastolic murmur is seen in mitral stenosis. Okay, mitral stenosis. Okay, mitral stenosis. This mitral stenosis murmur is associated with opening stamp, is associated with associated with mid-diastolic murmur, pre-systolic attenuation, and a loud S1. Okay, these are the characteristics of mitral stenosis. Okay, mitral stenosis, and it is very, very, very important for your exam. Okay, so this whole overall picture summarizes what we have discussed. Okay, what we have discussed. Okay, so this is very, very important thing for your exam. இந்த எக்ஸாமுக்கு இது வந்து ரொம்ப 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 அவசியமான ஒரு விஷயம். இது நிச்சயமா தெரியணும். ஓகே, பேசிக்கா யூஜி லெவல்ல இந்த மர்மர்ஸ் வந்து நீங்க தெரிஞ்சுட்டு போனீங்கனாலே more than enough. Okay, more than enough. Okay, then coming to the hand. Okay, hand of the patient. The hand of the patient has the tip of the fingers, the base of the fingers, and heel of the hand. Okay, so this heel, okay, heel, okay, is the one which is going to hear the heel. Okay, what is this heel? Heel are parasternal heaves. Parasternal heaves. Okay, these parasternal heaves are usually seen as a part of right ventricular hypertrophy. Okay, right ventricular hypertrophy. As a part of your right ventricular hypertrophy. Okay, then next is the base of the fingers is one which is going to feel the thrill. Okay, thrill or palpable murmurs. Okay, and the P. Okay, the tip of the fingers. Tip of the fingers is for pulse. Any pulsations. Okay, any pulsations you will feel with the tip of the fingers. Okay, this is the important thing you have to remember as PTH, pulse thrill heat. Okay, pulse thrill heat. Okay, that is very, very important thing to remember in your exam. Okay, remember in your exam. Okay, so hope I'm clear till now. Okay, there is no problem. Okay, so whenever you have any patient with heart murmur coming to you, a heart murmur coming to you, you have to see whether the murmur coincides with the carotid pulse. Yes, no. Okay, when it coincides with the carotid pulse, then it is going to be a systolic murmur, and if it is going to be a crescendo or decrescendo murmur radiating to the carotids, it is going to be aortic stenosis. Okay, whenever it is a holosystolic murmur radiating to the axilla, it is going to be a murmur of mitral regurgitation. Okay, mitral regurgitation. Okay, then whenever it is a diastolic murmur, if it is a decrescendo murmur, then it is going to be aortic regurgitation. Whenever it is a diastolic murmur, which is a mid-diastolic murmur, opening stamp is present, low pitch, rough rumbling quality, with a pre-systolic attenuation, loud S1, then it's going to be mitral stenosis. Okay, whenever you have an atrial fibrillation in patient with mitral stenosis, there will be no pre-systolic attenuation. There will be variable S1, no proper opening stab. Okay. So these are features of patient with AF. Okay, patients with AF. That is very, very important. Okay, very, very important. Okay. So this is going to be very, very important thing. Okay. Then what happens is you have to see murmur maneuver attenuation. Okay, murmur maneuver association. Okay. So what are this murmur maneuver associations? Okay. So very, very important thing is whenever a patient is in left lateral decubitus, it increases the mitral murmurs. Whenever it is leaning forward posture, it increases the aortic murmurs. Okay, it increases the aortic murmurs. Very, very important. Okay, very, very important thing. Whenever it is leaning forward, it increases the aortic murmurs. Whenever it is left lateral decubitus, it increases the mitral murmurs. Then, whenever it is a right-sided murmurs, right-sided murmurs increases on inspiration. Okay, because during inspiration, the venous return increases. Venous return increases. So this is what happens. Left-sided murmur increases on expiration. Okay, because during expiration, blood returns to left side of heart. Okay, very, very important. So these are few important things I want to tell you. Okay, very, very important thing. But that is what when this is very, very important thing. Okay, so this is very, very important. Okay, so these things are actually not important for your level. So we'll skip this. These things are very, very important for you at UG level. Okay, very, very important for you at UG level. So this is very, very important. Okay, very, very important thing to know. இது வந்து ரொம்ப ரொம்ப முக்கியமான விஷயம். இது தெரிஞ்சா நீங்க எக்ஸாம்ல வந்து மோஸ்ட் ஆஃப் த கொஸ்டின்ஸ் வந்து நீங்க ஆன்சர் பண்றதுக்கு ஈஸியா இருக்கும். ஓகே, ஈஸியா இருக்கும். ஓகே, now coming to the last one. Okay, here which is going to be I want you people you people wanted me to summarize la. So I will summarize the numbers. I will send you one second. Okay, this is one table which summarizes uh, all your doubts actually. Okay, all your doubts can be summarized here. Okay, so how we are going to summarize these things here? Okay, that is very, very important thing. Okay, so whenever you have any case of cardiac diseases coming to you, okay, now what you're going to do is you're going to go for certain things. Okay, so whenever there is a okay, okay, first thing is you're going to go for pulse, BP, JVP, apex B. Okay, then you're going to have any paracetamol heave is there or not, thrill, heart sounds, any extra sounds, murmurs. So these are the very, very important things you have to consider. Okay, very, very important things to consider. Okay. Now, whenever a patient is going to come to you, these parameters are very, very important in making a diagnosis. Okay, very, very important in making a diagnosis. And you have to always look for these parameters. Okay, these parameters. Okay. Then what is the findings which is going to give you clue here? Okay, the first one is going to be a patient coming to you with a low volume pulse. Okay, low volume pulse. What is this low volume pulse indicates? Okay, and BP is also low. Low volume pulse இருக்கு, low volume BP lower side ல இருக்கு. Okay, lower side ல இருக்கு. Okay, next JVP. Okay, JVP பெருசா there is no change. Okay, JVP ல பெருசா change எதுவுமே இல்ல. Okay, then next is apical impulses, tapping apical impulse. Okay, and because of right ventricular hypertrophy, the patient develops pulmonary hypertension. The patient develops pulmonary hypertension, and next important thing is the patient is going to have a loud S1. Okay, the loud S1. Okay, S2 is normal. S2 is become loud if there is a pulmonary hypertension, there is an opening snap, a rough rumbling, mid-diastolic murmur is here at the apex. What is your diagnosis whenever these features are there? Whenever these features are there, what is your diagnosis? It's going to be a case of mitral stenosis. Okay, mitral stenosis. You know the reason, right? ஸோ நம்ம கிட்ட இருக்கிறது வந்து 1 hour to 2 hours தான். ஓகே, ஸோ நம்ம எல்லா மெக்கானிசமும் நம்மளால இப்போதைக்கு டிஸ்கஸ் பண்ண முடியாது. பட் தீஸ் திங்ஸ் ஆர் self-explanatory, I think so. Okay. Then the second case where the patient is going to have, okay, the patient is going to have normal pulse or increased volume of the pulse. BP is normal, JVP is normal. There is a hyperdynamic apical impulse with a shift down and out. Okay, S1 is soft with wide split. Okay, A to P2 distance increases. Okay, and patient is having a blowing PSM radiating to the axilla. Okay, radiating to the axilla. What will be your diagnosis? So soft S1 இருக்கு. Then your diagnosis is going to be mitral regurgitation. Mitral regurgitation. Okay, then the third patient is going to come to you where the patient is having a low volume pulse, pulsus parvus retardus. Okay, and the patient will have a low systolic BP that is called as systolic decapitation phenomenon. The systolic decapitation phenomenon. Okay, so systolic decapitation, there will be a low systolic blood pressure. Okay, so it will be a narrow pulse pressure with a low systolic blood pressure. Okay, so this is very, very important. Okay, so that is seen whenever there is an obstruction. Okay, obstruction. Okay, the patient is going to have a heaving apical impulse. Okay, heaving apical impulse. Okay, then the patient will have a normal S1. S2 is soft. Okay, S2 is soft, and patient is going to have a harsh diamond shaped crescendo or decrescendo ESM in the second intercostal space, radiation to the bilateral carotids. Okay, and there is going to be something called Gallavadian phenomenon, which is, I will tell you what is Gallavadian phenomenon. Okay, so which is seen in which condition? It is seen in the case of aortic stenosis. Okay, aortic stenosis. What is this Gallavadian phenomenon? Okay, இது மாதிரி இருக்கு. ஓகேவா? இப்ப இந்த அயோட்டா, இந்த அயோட்டா. இந்த மாதிரி ஒரு அயோட்டா இருக்கும்போது இந்த பிளட் வந்து இப்ப வந்து enters into the uh, aorta. Okay, whenever the blood enters into the aorta, okay, what is going to happen is the blood is going to pass through a narrow passage here, stenosis. So it is going to enter into the narrow passage here. When it tries to enter into the narrow passage here, there will be resistance while passing through this area. Okay, where there will be resistance while passing through this area. Whenever there is a resistance in blood passing through this area, what is going to happen is the patient is going to have blood which is going to enter here like this. Okay, blood is going to enter like this. Because of the resistance, some amount of blood will get entering here, some amount of blood will be returning here. Okay, so whenever the person is going to have like this, what is going to happen is the patient is going to have a aortic stenosis ejection systolic murmur at second intercostal space, and they are going to also have a polosystolic murmur at apex of the heart. Okay, so this is going to be mimicking mitral regurgitation, and this is going to be called as Gallavadian phenomenon. Gallavadian phenomenon. Okay, Gallavadian phenomenon. Okay, so very important thing here is this Gallavadian phenomenon. Okay, so this Gallavadian phenomenon is going to be high frequency murmur here. Okay, that is, it's going to be a loud murmur. Okay, which radiating to the apex. Okay, so some people even call it as a musical murmur. Musical murmur. Okay, so this is going to be very important thing they can ask you in your exam. Okay, they can ask you in your exam also this one. Okay, இது வந்து ரொம்ப இம்பார்ட்டண்டா தெரியணும். Okay, very இம்பார்ட்டண்டா தெரியணும். Okay, this is called as Gallavadian phenomenon. Okay, next is a patient is going to coming to you. Okay, patient is going to coming to you. Okay, this patient is going to have increase in the volume of the pulse, collapsing pulse is there, pulses disvariance is there. Okay, double apical impulse is there, double peak. Okay, in the systole will be there, and patient will have a high systolic blood pressure with a low diastolic blood pressure, and increase in the pulse pressure will be there. Okay, increase in the pulse pressure will be there. Okay, and there is going to be a hyperdynamic apical impulse. Okay, and there is going to be a soft S1. Okay, soft S2. Okay, and the patient is going to have a early diastolic murmur. Okay, early diastolic murmur. Where you are going to get this pattern? This pattern is usually seen in aortic regurgitation. Aortic regurgitation. Okay, the same thing you can apply here in cases with tricuspid regurgitation. Also, here also you're going to get in similar to your mitral stenosis. So, like mitral stenosis, it is tricuspid regurgitation. Okay, tricuspid regurgitation. So these are few important things which is considered important for your exam. Okay, consider important for your exam. Okay, so this is going to be very important. Okay, so this is going to be very important for your exam. Okay, so this is going to be very important for your exam. Okay, so this is very important. Okay, very important. Okay, so this is about the different kinds of characters of murmur you get to see in our cases of cardiac valvular heart disease, which is very important for your UG exam. Okay, UG exam. So if you have any doubt here, okay, if you have any doubt here, I will explain it. Okay. Or if you want to know anything specific, we will discuss. We will discuss. We will discuss if anything specifically required. Okay. இது தவிர வேற என்னென்ன கேட்பாங்க அவங்களோட யூஜி லெவல்லன்னு பார்த்தா okay, aortic regurgitation. Okay, in aortic regurgitation, what are the signs, okay, which are very, very important? Okay, the first one is called as lighthouse sign. Okay, lighthouse sign. What is this lighthouse sign? Okay, lighthouse sign na alternate blanching and flushing of the forehead with arterial pulse. Okay, arterial pulse க்கு ஒவ்வொரு தடவையும் உங்க foreheadல alternating blanching and flushing இருக்கும். That is called as lighthouse sign. Second is Landolfi sign. Okay, Landolfi sign na என்னன்னா pupil வந்து with each cardiac cycle there will be constriction and relaxation. That is called Landolfi sign. Then Becker sign. Okay, Becker sign begs the retina. Okay, it is a retinal pulsation. Okay, which is called as Becker sign. Okay, then Mueller sign. Mueller sign வந்து uvula. Okay, uvula. Uvula pulsations. Okay, uvula pulsations is called as Mueller sign. Okay, Muset. Muset வந்து மண்டைய மியூசிக்கு ஷேக் பண்ணிட்டே இருப்பாப்ல. Okay, that is called as Muset sign. Music bob. Okay, so every time for the music the head bobs. Okay, so every time for the cardiac contraction the head bobs. Okay, that is called as Muset sign. Then Corrigan sign. Okay, Corrigan signs is going to be called as dancing carotid. Okay, dancing carotid. Okay, the carotid feels like dancing. Okay, so with each contraction there will be a distension and collapse of the carotid is called as dancing carotid. Okay, dancing carotid. Next is locomotor brachii. Locomotor brachii is going to be the brachial artery pulsations. Okay, the brachial artery pulsations which is seen evident in the medial surface of the hand. Okay, that pulsation is called as locomotor brachii. Okay, then Quincke's pulse. Okay, Quincke's pulse. Okay, so whenever you bring the nail bed close to another one object, okay, what happens? You can see the alternate flushing in the nail bed. That is called as Quincke. Quincke, whenever you bring it, you get it Quincke. Okay, Rosenbach, you get two things. One is rose liver, Gerard spleen, or rose liver, Gerard spleen. Okay, so systolic pulsation in liver is called as Rosenbach sign, and systolic pulsation in the spleen is called as Gerard sign. Okay, Gerard sign. Okay, Gerard sign. Next is Lincoln sign. Okay, Lincoln sign. Okay, so Lincoln sign என்னன்னா ஒரு patient okay, ஒரு patient கால் மேல கால் போட்டு உட்கார்றாரு. Okay, whenever he puts crossed leg, okay, இந்த கால் மட்டும் every heartbeat ஓட it moves forward and come backwards. Okay, கால் மேல கால் போடுறாரு, for example இப்படி போடுறாருன்னு வச்சுக்கோ, இந்த கால் மட்டும் ஒவ்வொரு ஹார்ட் ரேட் அப்பயும் மேல போயிட்டு மேல போயிட்டு மேல போயிட்டு வருது. ஓகே, இதுக்கு பேர் வந்து லிங்கன் சைன். ஓகே, லிங்கன் சைன் which is whenever the legs are crossed over each other, the leg moves forward and comes backward. Okay, this is called as Lincoln sign. Okay, the next important thing is hill sign. Okay, what is this hill sign? Okay, hill sign we already saw systolic blood pressure minus diastolic blood pressure, and normal is going to be 30. Okay, 30. Okay, normal is going to be 30. Okay, so to 60. Okay, whenever it is increased, then it is going to be significant. Okay, then pistol shot murmur. Okay, what is this pistol shot murmur? The sharp sound heard over the femoral artery. Okay, during rapid ejection of blood into the aorta. Okay, அப்போ வருது pistol shot. Okay, pistol shot na The gun length varame or sound varo. Okay, it is called pistol shot murmur. Okay, so this is very very important. Okay, and neurosis sign, it is a double intermittent murmur heard over the femoral arteries. Okay, femoral arteries like you are going to hear a double murmur. Okay, or murmur or a space or murmur and a very double intermittent murmur heard in the cases of femoral artery is going to be called as neurosis murmur. Okay, neurosis murmur. Okay, or neurosis sign கூட சொல்லுவாங்க. Okay, it is very very important. Okay, so it is a femoral artery whenever you are going to compress with bell of the stethoscope. பெல் ஆஃப் த ஸ்டெத்தஸ்கோப் வச்சு நீங்க கம்ப்ரஸ் பண்ணும்போது ஒரு டயஸ்டாலிக் டபுள் மர்மர் டயஸ்டாலிக் டபுள் மர்மர் இருக்கும். தட் இஸ் கால்ட் அஸ் டியூரோசிஸ் sign. Okay, neurosis sign. Okay, very very important thing. Okay, very very important thing. The next thing what they can ask you is uh, what is hill sign கேட்கறதுக்கு சான்ஸ் இருக்கு. Okay, hill signs கேட்கறதுக்கு சான்ஸ் இருக்கு. So whenever you have hill signs, it is a sign of aortic regurgitation, and whenever the systolic blood pressure minus diastolic blood pressure is more than 60, okay, then it is going to be significantly indicating that the patient is having aortic regurgitation. Okay, and this hill sign can also be used to assess the severity of your patients with uh, aortic regurgitation. Okay, aortic regurgitation ஓட சிவியரிட்டிக்கும் நம்ம யூஸ் பண்ணலாம். எப்படி யூஸ் பண்ணலாம்? Whenever you have any patient coming to you with aortic regurgitation, okay, what you are going to do is you are going to check for the hill sign. Okay, hill sign. After checking for hill sign, what is going to happen is you are going to grade it. Okay, grade it. How you are going to grade it? Whether it is less than 16. Okay, whether it is less than 16 பார்க்க போறோம். Okay, next என்ன பண்ண போறோம்? இந்த less than 60 இருக்கிறத மெஷர் பண்ண பிறகு the next step is it is going to indicate severe aortic regurgitation. Whenever it is 40 to 60, then it is going to be moderate. Whenever it is less than 40, then it is going to be mild. Okay, it is very very less than 40. Okay, less than 40 is mild. Okay, so this is called as hill sign. Okay, very very important sign. Okay, very very important sign. Okay, so this is about the aortic regurgitation features. Okay, aortic regurgitation features, and these aortic regurgitation features are very 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 important thing for your exam. Okay, very very important thing for your exam. Okay, so இது வந்து ரொம்ப 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 இம்பார்ட்டண்டா உங்க எக்ஸாம்ல கேட்கக்கூடிய ஒரு விஷயம். இது தெரியாம எக்ஸாமுக்கு போகக்கூடாது. எக்ஸாம் வந்து ரொம்ப 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 important. Okay, then another one thing is in aortic regurgitation you have another murmur called Austin Flint murmur. Austin Flint murmur. Okay, what is this Austin Flint murmur? Okay, so இது எங்க வரும்? aortic regurgitationல வர ஒரு murmur. இந்த murmurோட significance என்னன்னு பார்ப்போம். Okay, so whenever you have a patient with aortic regurgitation, இந்த murmur என்ன பண்ணும்னா இந்த blood flow என்ன பண்ணும்னா will come and hit the mitral wall. இந்த murmur வந்து இந்த blood வந்து mitral wall hit பண்ணும்போது you hear a mid diastolic murmur similar to our mitral stenosis, and that is called as Austin Flint murmur. Okay, Austin Flint murmur is a mid diastolic murmur, purely mid diastolic murmur. Okay, it will not be extending into the late diastole like our mitral stenosis. Okay, so it is going to be here in the fifth intercostal space, the mid clavicular, right? That is called as Austin Flint murmur. Okay, Austin Flint murmur. Okay, so this aortic regurgitation flow is going to go and hit the mitral wall. Okay, preventing the opening of the mitral wall, so that it is going to be a mid diastolic murmur. Okay, which is called as Austin Flint murmur. Okay, Austin Flint murmur. Okay, இது எப்பவுமே S3 க்கு அப்புறம் வரும். Okay, அதுவும் நீங்க கேட்டா சொல்லிக்கலாம். S3 க்கு அப்புறம் வரும். Okay, S3 க்கு அப்புறம் வர ஒரு murmur. Okay, S3 க்கு அப்புறம் வர ஒரு murmur. Okay, it is more detailed. Okay, so this is about the different characteristics of your uh, cardiac diseases. Okay, cardiac diseases. Okay, so anything specific you want more? Anything specific? I will erase everything. Okay, here so that it is easy for you to revise. So anything you want to know in cardiology more? Okay. So we are left over with the two things. First is CNS, second is abdomen. ஸோ நாளைக்கு என்ன பண்ணலாம்? நாளைக்கு என்ன டாபிக் பண்ணலாம்? CNS. So, okay, tomorrow we will go for CNS. Okay, tomorrow 6:30 to 7:30 we will have CNS. Okay, so இன்னைக்கு நைட் வைக்கலாமா கிளாஸ்? if possible I will let you know by 7 o'clock, 7:30. Okay, night ஒரு கிளாஸ் இருந்தா நான் வந்து இன்ஃபார்ம் பண்றேன். we can do it. Okay, so I will ask in the group. Okay, I will ask you in the group. Okay, so till then study well. Okay, so if you want anything extra, inspection அப்ப you see for the ala ACI. Okay, first one it will அந்த goatக்குலாம் போற மாதிரி it will flutter. Okay, then sternocleidomastoid will be prominent. Okay, then increased work of breathing, the intercostal muscles will be hyperactive. Then your scalenus muscle will be contracted. So all these indicate that accessory muscles are hyperactive. Okay. Okay. So with this, we'll finish today's discussion. Now, on the 7 o'clock, 7:30, I'll message you about the night class scenario. Okay. Thank you all. Bye bye.